been an occupational therapist for 43 years. So just had a little bit of experience. And I did my first home assessment actually before I graduated. So back in 1980. And then in 1983, I built my first accessible house. And for the last 7 years, I retired from being a professor at university and did a home mods business and have built that up. And now I've been doing coaching and developed a certification program. But I've also learned a lot in that process. And one of those was definitely figuring out when to bill Medicare, because I figured first I'm just going to do a cash pay practice. And I learned a lot about that not being possible. So let's go on and have a look at some of the things that we're going to be looking at. And Lauren, we will address that as well. So 5 points: understanding some of the growing demand and things to look at, looking at ways to develop expertise, understanding reimbursement areas and Medicare coverage, and we'll be open for questions. So, keep those coming as you need. And then understanding and networking with professionals in your community and staying up to date with equipment, technology, and funding sources. And the statistics on falls are pretty bad, actually, when you look at it. 1 in 4 older adults fall every year. And then the leading cause of fatal and non-fatal injuries for persons over 65. And then 37% of falls require medical treatment and restriction of activities. And they actually resulted in 78 per 100,000 deaths for older adults in 2021, and for 83% of all the hip fractures, right? They were also the most common or frequent cause of TBIs in adults. So you can see they have pretty horrific consequences. Thanks, Lauren, for looking at that. Yes, if you want to speak, just go ahead and I will let you. You can do that. Every 11 seconds, an older adult is treated in the emergency room for a fall. That's pretty scary when you think about it. We're 6 minutes into this. And so that would be at least 36, 37 falls, no problem at all in that time frame in the emergency room, and that doesn't account all the other falls. Every 19 minutes, an older adult dies from a fall, and the cost to the U.S. healthcare system in 2022 was $50 billion and expected to grow. And there's lots of other complications aside from fractures and TBI that we think about. There's depression, sleep disorders, and stress. Basically, we see a lot of PTSD in adults who have had significant and serious falls. And risk factors, we know lower body weakness, obviously, but there's some new research looking at upper body weakness as well as contributing to it. And part of the reason for that is if your upper body was strong enough, you could use it to catch yourself, excuse me, or be able to use it to support yourself on other equipment, etc. Vitamin D deficiency, difficulties with walking and balance, medications, vision problems, foot pain, poor footwear, and home hazards. And home hazards is in there, but these are all of the things the CDC listed. Just a good review for us because most of us are familiar with those. Where do we fall? If I was to ask you where you thought the most dangerous place in the house was, what would you say? Because 74% of all falls are inside. So what would you say would be the most dangerous room in the house? Well, the answer is written on the sides here. It comes first in this list. It was actually the bedroom. Even though I see a couple people with bathroom, I would have thought that too. Actually, realistically, they were probably all within the statistical significance of each other, but bedroom kept winning out in about 4 different studies. The bedroom was actually at around 34%, living room around 33%, and the bathroom around 32% in most of the studies. So that's kind of interesting because we focus a lot on the bathroom and don't think about the others. Once you get outside of those rooms, the stairs were then the next most common location. and bathroom and stairs were the ones that commonly resulted in injury. And if you think about it, they have hard surfaces and longer distances to fall. And then 1/3 of the falls were due to tripping or slipping. If we look per state, this was kind of interesting. When you think those dark blue areas are the ones that have the highest percentage of falls, and the very light or white blues, such as Illinois, had the lowest percentage of falls, which is kind of interesting. You can think about some of these as being snowy, wet, rainy in winter, darker during winter, but they have neighbors right beside them where that's not the case. So it's really hard to know how to associate what related to the weather causes that. And for some reason, my picture here did not link up. And so the thing with this picture here was to show what were we started all over again. What were the more common states for us to actually have falls in? And if we look at this, we can see Alaska was the highest falls, South Dakota and New Mexico in terms of percentage of falls. Then Illinois, Hawaii, and Connecticut had the lowest area of falls. And then when we look at death rates, it was Wisconsin, Minnesota, and South Dakota that had the highest death rates for falls. And the lowest was Alabama, New Jersey, and California. So I'm not sure what factors they weren't able to give us a breakdown of what caused that there, but it was definitely a factor in making the risks higher in those states for injury and death. So now if we looked at the demographic shift that we're having, we can see that the number of Americans aged 65 or older is expected to increase. So we really know there's going to be a lot more people who are having problems out there. The U.S. population is older than it's ever been, with the median age now being above 40. And in states like Maine and New Hampshire, we're talking about 44, 45. And the older population is more racially and ethnically diverse. And also what we're finding is that the whole racial mix is changing, but that some races are more at risk for falls and more at risk for damage from falls. And we're going to look briefly at that. But if we can see, when you look at the positive developments, we're seeing that home modifications are increasing and that people are staying independent longer. I know with the recent experience we've been through with COVID, there were a lot of people that saw what was going on either in nursing homes or had family members in nursing homes. They were unable to visit them. Family was unable to be engaged and no longer want to do that. So most people want to stay within their own homes. There was a large percentage before, but that percentage has grown. And in reality, most people continue to live in their homes well into old age. So as we look at that, some of the challenges, and this comes into when we do home assessments, that gains in life expectancy has stalled, but we're seeing increasing obesity. We're seeing wide and broad economic disparities. We've also seen more people living single, as in there's older divorce rate and more women living alone longer. And then there's also that caregiving gap, because we are now seeing a shortage of caregivers. And I have to tell you, this is worldwide that we're seeing this, because my family live in Australia. And as I'm looking at, my family situation there, I went home in February to see my parents. It was very aware that caregiver shortage is really significant there as well. And then we're talking about budgeting and finances as being a problem for funding that. The other part that plays into this that's really important to consider is the age of the home. And that's a contributing factor that we don't often think about. The median age of an owner-occupied home now is 40 years old. And 40 years ago, we definitely weren't thinking about accessibility, right? We definitely weren't looking at, can we get a wheelchair in here? What does this look like? All of these kinds of accessibility issues. In Housing Fit is worse as we get older, and is even worse when we're talking about Black and Hispanic residents. They tend to be in poorer neighborhoods that have smaller rooms, smaller and more difficult entrances. 1 in 10 adults over the age of 80 are reporting difficulty getting in and out of their home. And that's where home modifications can come in. They improve the housing fit. Less than 4% of homes, though, can be adapted to accommodate a wheelchair easily. I mean, any home can be adapted, but we're talking about cost and design issues. And 0.15% in the US are actually wheelchair accessible. And 5% of American households report one person having difficulty navigating in their home. In the difficulty accessing the bathroom and kitchen were the biggest problems that they found. All right, let's move on to this. So you can see when we're talking about disability and percentages of disability, as people age, this is for people under 50 here. This orange one is people 50 to 64, then 65 to 79, and then 80 and older. You can see the percentage having any disability increases and the percentage with mobility increases. And you can see that up to 40% in the 80 and older age group have difficulty with walking. And you can also see that that continues to climb. So it's almost 1 in 4 in that age group 65 to 79. And then you can look at, the cognitive impairments, self-care impairments, and being able to get outside and shop. So we know that that's definitely a significant factor. And then they've put here populations that have difficulty with any kind of navigation within the home. And this is 1.6 million people in the population that was surveyed. So it's definitely an issue, and home mods is definitely a growing need. In so much so that when Steady looked at what was happening, falls were costing, as we saw, Medicare a lot of money. So they put out the Steady screening and the Steady algorithm. Has anyone seen or used this? This is a great resource for us, and there's several handouts that we can use with patients or we can order free. And so with this screening here, you can see that when healthcare providers are treating patients, and this actually applies to us as well, you can see that there's a 12-question tool that you can use, Stay Independent, which is available on their website. And if anyone has a score of less than 4, they're fine. If they are higher than that, we need to look at the risk factors. But also the question is, have they fallen, right? And then do they have a fear of falling? And when we look at this, one of the recommended options here is obviously refer to physical therapy for poor gait, strength, balance training, right? Or to another evidence-based exercise program. But the other one down here is refer to occupational therapy for a home safety eval and assessment. And so we know that this is definitely a recommendation. Why did I pull up the CDC brochures? Because we're going to look at in a minute that Medicare uses these to define recommended quality measures and procedures for providers. And so that's where we're going next. And this is the CMS Merit Incentive Payment System. And so in this system, what happens is the providers who have a higher volume of about 90,000 a year billed to Medicare must opt in, and other providers are able to voluntarily opt in, and this includes physical and occupational therapists. And if you follow their recommended plans of actions, and you note that in recording this, then you actually get a higher reimbursement rate. And so one of these ones, 100 CMS MIPS 154, calls for fall risk assessment, right? And so when a provider is seeing a patient, every year they need to, so it says once per performance period. So every year they're supposed to do this screening with their clients over 65 that are on Medicare. And by doing so and then taking the action and how they note it, they will be able to increase their reimbursement. So when you look here, that assessment looks at specifically asking the question, have you fallen? Have you had an injury fall? So you can see here, this screens for, has the patient had 2 or more falls in the past year or any injury fall in the past year, right? And then they must look at these assessments: identification of fall history, assessment of gait and balance, muscle weakness, and they pretty much use the same guidelines that was just back in the study assessment. In the assessment of visual impairment, cognitive impairment, urinary incontinence, they're supposed to ask about home hazards and cardiovascular examination. Then they get even better scores if they actually donate that they did a plan of action related to that. And as we can see here, that plan of action is related to looking at having identified the risk factors, then looked at recommendations for home safety assessment, adaptation and modification of the home, looking at medications, postural hypertension, footwear, exercise, particularly balance, strength, and gait training. So it says here they should be offered these programs, and there should be multi-component interventions. And this is where we fall in here, so that we can actually provide these services that then helps reward the medical provider with a better payment system under Medicare. So what does that mean? Does Medicare actually cover us doing home safety assessments? So in 2016, when I started my practice, I was going to be all cash paid. And this is where, please, if you have questions, go ahead and put them up. I was going to be all cash paid. And my little office, I was mobile and had a little office, but my little office was near a chiropractor's office. And the wife there did all their coding and billing, and she had just done a lot of courses in coding and billing. And I was telling her, this is what I'm doing. And she said, do you realize you have to bill Medicare? And I was like, no. And so I did a lot of searching then. And I found out that Medicare does cover home safety assessments, particularly based on what I saw in the MIPS and based on the fact that we can bill both in a clinic and in the home setting. And so I presented a presentation before the AOTA conference in 2019 saying that, and that created quite a buzz. And AOTA ended up hiring an attorney to study the matter for 6 months. In what they said, there are 3 scenarios here. And the 3 scenarios are that there's one, a medical condition resulting in functional limitations, and the patient requires treatment for that, as well as the home safety assessment, that they're having problems completing their self-care within the home environment. And so in that situation, that is definitely a billable to Medicare service. And that is one where we would establish usual Medicare protocols of plan of care, etc. The third scenario they came up with was, for example, someone had a stroke 7 years ago. They're now currently stable with that, but they're thinking, oh my goodness, I have this history of stroke. I'm thinking I might have another one. I should prepare because before I got better or somewhat better after it, I was having difficulty managing at home. In that situation, it's the therapist's discretion whether it's medically necessary or not, and you would document based on that. And that would be the deciding factor of whether it's billable to Medicare. The description of the case that I described in terms of this person's disability from the stroke has been stable or somewhat resolved, and that is no longer causing these issues, that would be one not billable. But if the person had a stroke and then has recently had a fall, or a person had a stroke in the past and now is having TIAs, that would add to this now being medically necessary and covered by Medicare. The other situation that they outlined was that someone who is a Medicare beneficiary is looking at, I'm getting older, I've retired, I need to make my home accessible because I want to live here until I die. But there's no urgent medical condition or change in their status that is pushing that. They're being preventative. This is a small percentage of the population, to be sure, but this is the true aging in place requirements, right? In that person, it wouldn't be billable. The other situation is if you have someone discharging from the hospital, but they're not present. Like the family is wanting to get this all set up before they come home, and the client isn't present. You're only assessing the environment. You're not assessing the interaction between the client, their occupation or activity, and the environment. You're just assessing the environment. In that situation, that's not billable. Someone in skilled nursing, the same thing, right? That's not billable. You've been hired by a building contractor to help make this home design that they're using, that they're looking at, to be accessible, but you're not assessing the client or you're not treating the client. That's no longer a billable situation to Medicare. Any questions about that? Because I know several of you came here wanting answers regarding that. So use the speak option or write a question in the chat. Nobody has questions? The link here, you'll be able to access the handouts. The link here is actually to that AOTA statement from the attorneys and from their policy and procedures person. And this applies to OTs and PTs because there is no difference in terms of the legal obligations that were found there. All right. So one of the things to think about in this aging in place and in fall prevention and home safety and modifications is we have a unique role. There are so many different people out there trying to get into that market right now. Yes, let's see who wanted to speak. Would any of this be billable under caregiver training? So there's a couple of issues related to caregiver training. One is that the client is not present, but you're in the home for caregiver training. So there may be some times when that occurs, right? But if the client's receiving Part A benefits, that's also not going to be billable. For example, the client's in the hospital, but you're working with the caregiver at the home, or the client's in a skilled nursing facility. In that situation, the client is already receiving Part A benefits, so you couldn't bill under those Part B outpatient codes at the same time. But if the client was there for your original assessment, you did those options, then you could definitely bill on a return visit or caregiver training. In my perspective on home safety modifications, it's not a one and done. We make recommendations. We need to make sure those recommendations work. We need to follow up and train the client and the caregiver in utilizing those recommendations. And in fact, in Australia now, I did some work with one of my colleagues when I was over there in terms of this discussion. It's coming here too, but therapists, and in Australia, it's particularly OTs, are being held responsible for recommendations that don't work, right? And that's not saying you have to get everything right straight away, but that's saying you need to be following up and you need to be making sure they're being used, and not addressing the issue is still going to hold you liable. In the classic situation, and that is actually my father himself, who had a home modifications done in Australia. The therapist came out and they were doing the transfer, her and the equipment demo with a Hoyer lift. My parents are well in their 80s. My mom is 81 and my dad is 86. My dad has been in a power chair for many years. He was independent in transfers until he got a virus 2 years ago. And he was not given therapy in the home, in the hospital. They just said, oh, you're dependent, and sent him home. In that situation, they actually tore my dad's scrotum doing the transfer, but expected my mom to do that transfer by herself. So the two of them who were experienced in this expected my mom to do that transfer by herself. So of course, my dad isn't getting out of bed, or he's staying in his wet and soaked and soiled diaper all day after the caregivers get up, because my mom can only do one transfer. So there's a lot of issues related to, are we making sure this is working? Are we following up ethically as well as legally in terms of that? Tamika, I see you have a question. Let's say a non-medical home care agency hires the OT to do safety assessments for new clients. The agency does not accept Medicare. Does the OT have to bill Medicare? No, you're being paid by another agency to do this. That will negate your obligation to Medicare. And that situation, because in reality, your client isn't the patient and family member. Your client is actually the non-medical home care agency. Does that make sense? And that is actually in that third scenario that AOTA put out with the attorney. All right. There's a lot of other people competing out there, but as therapists, we need to argue for what is our unique role. Because as contractors say, well, I know ADA, I've done my CAP certification, I can do this. Well, yes and no. I always say ADA, first of all, does not apply to the home at all, right? It is for public buildings only. It does not apply to the home. And secondly, the ADA standards were built for young spinal cord injury clients coming home from the Vietnam War. That's where they started. That's where they were developed from. And when we look at that, and we've done studies, the ADA recommendations, particularly like for toilet transfers for our seniors who do stand pivot transfers, actually increase their fall risk, not decrease their fall risk. And so we know that ADA for the home is not effective. It may be a good starting place for us in our clinical reasoning, but that should not be where we end our decision making or where we end what's happening. So that is really important to understand, that A, it doesn't apply to the home, and B, I refer to it as like hospital socks. We've all had experience with hospital socks, right? Fits everybody, really fits nobody well. Okay. And the reason we need therapists to be doing these assessments is because we truly can do that relationship between the client, their functional abilities, and how the environment impacts on that. And so that really gives us a unique role there that allows the package to be much more client-centered and client-focused. I've had discussions, and we're doing more presentations with architects and looking at training with them. And, these architects are saying, we can design the space. We can tell you about interactions within or around the space in a broader concept, but we don't understand the client's medical condition, how it's likely to change, what kinds of things are going to likely pop up as a scenario, what happens for this particular client in this setting, how are they used to doing the transfer, how does their body mechanics affect the components that are needed. So that is really the key and unique role we have, is to make those changes customized to the client, client-centered, and working and functional for them, their caregiver, their setting, their valued occupations. And so that is really why we need to still be fighting for us to be in that setting. All right, any questions on that piece? All right, so the next thing to think about is, okay, it is a Medicare covered service, but that means we don't have to bill Medicare, right? We can just take cash from a Medicare client. And there are 2 regulations that actually stop that from being the situation once we've decided it's a covered service. Firstly, therapists are not allowed to opt out of Medicare. We are not on the list where that's an option. And so we can't provide covered services to a Medicare beneficiary and charge them for them, right? We have to be credentialed with Medicare. And then there's the mandatory claim submission. So even if you're not credentialed, you still have to submit the claim to Medicare. In that regulation, which I have there, has a $2,000 fine per violation. Now people say, well, they won't know. How will they find out? I'm not entirely sure how they find out, but I've seen a couple of people actually in the last 6 months actually get letters notifying them that they violated that. The other thing is our seniors have paid into Medicare. This is a benefit that they want to use where it's applicable. Now, again, some people want Medicare to cover everything. Some people want Medicare not to do anything, right? To stay out of their lives. So it's really going to be knowing, where your obligations are and what kind of clients and stuff that you need to have. And this, just why is it important? Research has demonstrated following outcomes: reduced costs, reducing hospital readmissions, reducing health decline, improving quality of life, reducing falls, improving caregiver efficacy. And that's where that caregiver training comes in. That caregiver training code is actually used if the client's not present. But when we are training caregivers, we're just going to be able to build the CPT code that best reflects what we're doing. PT, you may be doing it in gait training, you may be doing it in functional mobility, ADL, self-care tasks, or OT, particularly for any of those. And that's where you would actually build the coding related to that training when the client's present. Now, do we need to develop expertise in this area? I'm going to tell you, I've been doing this for almost 40 years, 37 when I started just doing this solely as my practice. And we have the basic skills from our professional training, absolutely. But just like driving assessments, we know exactly when somebody probably shouldn't drive, right? The absolute worst case scenario. But it's all those nuances in between and making this gradation. Home modifications is like that. In our training, we get some basic skills, but it's now really becoming an advanced skill. There's a lot more needed and related to it. It's different, but related to the skill for fall prevention, which focuses on maintaining balance and strength, but again has a different focus and component with it. And I like this quote, which is from me, but I like how I worded this. While the solutions may appear simple, right, the reasoning to make sure it's the right solutions can be very complex. So understanding all the nuances and components in there is really important, and looking at your education. I'm just going to put a word here about certifications. There is the CAP certification from the National Association of Home Builders. There's the CLIP, Certified Living in Place Professional. There's the Executive Certificate in Home Mods from ECHM. I'll talk about Senior Home Safety Specialist in a minute, but those 3 look particularly at architectural modifications, and they are available to anybody. They're available to kitchen cabinet salesmen, bathtub salesmen. And so they repeat a lot of what we learned in our professional training, but they also miss out on a lot in terms of our professional responsibilities, our specific clinical skills and how they relate to this. And they also don't teach us about our obligation to Medicare and our professional code of ethics. And so that's why I developed the Certified Home Accessibility Therapist program back in 2020. And it was the HAS then. It's now being changed to Certified Home Accessibility Therapist. And so I have a special training program for that, which is 26 hours of self-paced work. So we go into more details about laws and regulations, including Medicare, impact of falls, ethics, understanding therapy approach to home mods, looking at behind the walls, knowing what is there. Also looking at understanding construction, floor plans, drawing those up, all the specific standardized assessments that are available, client factors, then the basics of ramp design, grab bars, looking at bathroom modifications from simple to complex, looking at basic products that we use in the home, and looking at things before your first visit, during your first visit, after, telehealth, billing and coding, writing effective reports, and funding cash-based services. So you can see there's a lot in there. The course is $825, but between now and July 31st, we are running a sale with a $50 off coupon that says July 4th. This is available on my website. The senior home safety specialist is more focused on safety checklists, but it's safety from the perspective of fire extinguishers, etc. It does do some of the pick up the rugs and all of those kinds of things. But as therapists, we do more than just an environmental check. We do that interaction between the client and their environment and the occupation and the caregiver, which is something that we have the unique role for. So thinking about what is important in your community. Tonight, after I'm finished this, I'm actually doing a presentation with the local fire department for people with dementia on safety. And so those are going to be, yes, there are credentials earned and a certificate, and you do take an exam. And so most licensures and states can accept that for it, and I'm getting AOTA accreditation for it. So if you're an OT, that would be it. But yes, that you do get a certificate. You get to use the logo, and we have some. You get to use this logo on your site and on your stuff. And there's also some handouts and things, and we actually have some merch coming that you'll be able to use as well. And then we have a graduate group. I'll talk about that in a minute. Local Falls Coalition's another place to look. Rebuilding Together, Habitat for Humanity, in-home care providers, Tamika, like you were talking about, DME providers, any person that is supplying a power chair or electric wheelchair to a client has to verify that the house is accessible. And so this is the classic case where I get called in by the DME providers, do the wheelchair assessment, but also do the home assessment at the same time, or come back to do that. And there's been 2-3 times now in the last year where I did an assessment. One, the DME provider just called me in and said, look, I've done the wheelchair with another physical therapist, but I need you because this house isn't accessible and we need to resolve this. The other one was the same situation. And this was a young man with ALS. And so we did a whole lot of adaptations for that young man that we were able to get funded through a nonprofit with that. So that was being a DME provider referred to me and said, I'm doing a wheelchair assessment, but this house isn't accessible. And I'm doing it with another therapist, but I know your skills in home mods. So I want you to come and do this component. The other two were ones that I went on to do the wheelchair assessment. And when we got there, we noticed the home was not in an accessible situation. So between then and when the wheelchair was delivered, the clients and I worked on getting the home wheelchair accessible. So, those are good relationships to have in your area, as well as if you're doing home mods. these are the people that may help you with those advanced adaptive equipment, because when we're doing home modern home safety assessments, we are able to look at, are there client factors we need to modify, or are there task factors we need to modify? Would adaptive equipment make a difference? Or do we need to go to architectural changes, right? Because we can look at the whole range of things. Whereas, for example, if you were, my husband says this a lot, if you go to a surgeon to ask for a surgeon, what his option, if you ask a surgeon what his opinion is, sorry about that, you would then get either surgery or I can't help you, right? And so in that situation, it's if you ask a contractor or someone who has a vested interest in it being a construction answer, they're going to give you a construction answer, right? As therapists, we can advocate for our clients across a range of solutions. And so that's really one way to do that. How do you network with Rebuilding Together and Habitat for Humanity? I found that they've had their own people to do assessments and are not open to someone else coming in. It really depends on your particular Habitat for Humanity or Rebuilding Together, how they're set up. And that is definitely one way. The other thing is to look at volunteering, look at meeting up with groups in your area, getting people to know what you can do. In geriatric case managers, so there's nurses now that are managing people in adult family homes or people who are being cared for at home but have significant medical problems. Those are great to reach out to. Elder law attorneys who do guardianship and trust and components like that. I've had an OT who does home assessments actually get, when the elder law attorney is starting to work with them, part of their package is to look at, do they need to modify the home to stay there? If they're looking at trying to work so that they can go on Medicaid, doing home modifications, not for beautification, not to update it, but doing home modifications related to a medical need or an accessibility need. So, for example, it came from our report, is a allowable spend down for someone to medicate. So they can upgrade the home in that way to make it accessible. And we're seeing even senior financial planners now that you can work with to have people look at, okay, I want to stay in this home as long as possible. What is the financial plan I need to look at to make this home accessible as we're going down this route? All right. Staying up to date. So we have the Home Accessibility Therapist Facebook group. We have a lot of discussions in there. Do have a newsletter. Hopefully you signed up for that when you signed up for this. If not, feel free to. It's on the webpage. Join the AOTA community of practice if you're an occupational therapist. We have an environmental modifications group. I'm now involved in part of that. Enroll in our CHAP, Certified Home Accessibility Therapist Graduate Network. We have lots of opportunities in that. We have lift people coming in. We have bathroom equipment people coming in. We have architects coming in. So always looking at updating what we're doing there and providing those resources. All right. So any questions there now, or things I haven't answered, or things that you would like to have more discussion about? Glad that was helpful. Jared, good. Yeah, if you have any more questions, feel free to reach out to me. I never thought about elder law. Yep, going on your list. Absolutely. And it really depends. And sometimes these networking, what we know from marketing science is that it takes somewhere between 8 and 11 touches. So thinking about how you're going to do those touches with your clients, how you're keeping track of it. We can't all do it in person all the time, but things like a newsletter in your area, things like then being able to just go back at Christmas or, Thanksgiving or something with a little basket, or thinking about ways to do that. But it really depends on making those community connections. And so sometimes some of the networking groups for small periods of time where you can meet people, there's senior care professionals in a lot of communities. Even sometimes the Chamber of Commerce, you can find some of the attorneys. In my little small Chamber of Commerce where I was when I started my practice, there was an elder law attorney there that we were having discussions with to look at working with them on that. So those are all places. Any other questions? Found any resources to support funding? Yes, we had some really great presentations on funding in our grad group a while ago, and so I have updated all the stuff in the course. Jared, Aaron, there we go. You should be able to speak. Did it accept it? Yes, and we actually found a specialized GoFundMe that is set up for medical situations like this, and they do focus on, they originally started focusing on transplant patients, but they actually really focused on home mods. What does billing look like for non-Medicare insurances and being an out-of-network provider? So again, just like with any other services, you call and get it covered. Find out if there's coverage. Otherwise, it's cash-based. And since you're using CPT codes, so you'll be using eval codes and self-care codes, you would print out a super bill if they want to try and do that. I've had my services covered by different agencies under Medicare and Medicaid, under Medicaid waivers, by workers' comp, several by workers' comp, and then several private pay, and then under some other agencies that were using their own funding that were nonprofits. All right, any other questions? Medicare, do you write a plan of care? I write a plan of care with limited visits, this is going to be, and then this is going to be done. And then when the new certification date comes up, I either rewrite it, or when I go back to see them, I update the plan of care. But my plan of cares have been anything from 3 months to 6 months long, just having to recertify them at that 90-day period. So all right. Any other questions? We've had a couple more. Sarah, did that answer your question? Okay. All right. Well, you all have a good evening. Thank you for taking the time to join this webinar, and then we will hopefully be seeing you in the Facebook group or on some of the other things. So take care. Talk to you all soon, hopefully. Good, Sarah. I'm glad that was exactly what you did. You're welcome. All right. Bye.